Thank you very much for the kind invite. We're going to talk a little bit about this new product that's come through. But before that, some basic things to talk about, which is the reason it's captured the imagination of a lot of people is because it's something, we live in a very different era. That's the sort of reality. I'm going to show you why. Because we'll talk a lot about why isn't obesity as simple as why didn't you run more and eat less? Because if it was that simple, we would have sorted it for everybody. And I'll give you an example. We've got a room full of people who are connected in the healthcare field. How many people in the room follow the WHO advice as regards exercise? 30 minutes, moderate exercise, 5 times a week. Please put your hands up. About 20% of the room. How many of you follow the WHO recommendation on food? 5 fruits and vegetables a day. Hands up. Just to those of you putting your hands up, tomato ketchup is not a fruit. It won't count. Okay? The point I make is that in a room like this, where we all know what is right to be done, only 20% of people have put their hands up or less when it comes to food. Why is that? Is it because you're lazy? Is it because you don't care? Is it because you're not trying? Or is it simply because life gets in the way? And that's what happens with everybody. After a whole week of working, when it comes to Saturday, you all probably know that we probably should exercise. The only problem is you're so tired after the whole week that you need to sit down and watch probably some Netflix. And that's just life as it is. So in this era has come this new drug, which is why everybody's turning to it, right? Something is like, okay, it works. So our job as doctors, and I'll put it very simply to you, how should it work for us as doctors is one simple question. So I'm going to ask you one more question. Think of your most loved one in your life, whoever it is. Your mother, your father, your son, daughter, mother-in-law, whoever you want it to be, all right? Spouse is above everything. I mean, we cannot even put the spouse in that debate circle. It will just create domestic issues. Let's leave her or him out. So let's talk about the most loved one in your world, in the world. If they have a particular, let's say, obesity-related problem, the question you need to ask yourself, do I find this product good enough and safe enough to use on my most loved one, right? And if the answer in your head after this session is yes, then you should give it to your patient because you're going to give it to your most loved one. The debate about the economy and whether they can afford it is a secondary one. We need to get to it. But as far as the science is concerned, that's not just for this. This is for every drug and every technology that we use in. If it's good enough and safe enough for our most loved one in our life, if it's my mom, my dad, my son, my daughter, then it's good enough for my patient, right? Okay, so with that in mind, one of the things I wanted to raise, obviously disclaimers, disclosures, evolution. I don't know why a lot of you chose to do diabetes management. I'll tell you why I chose to do diabetes management, because when I started off doing diabetes management was very... What do we say to people? Run around, eat less, try some metformin, try some glycoside, have some insulin. Thank you. That was it. That's all we had. And then things changed. We had GLP-1s, we have SGLT2s, and this very much shows where we have gone. That's the improvement. We're in an incredible era of type 2 diabetes, drugs that make disease modification newer, and we've all had to learn as we go along. So in this world has arrived this particular product. And as you can see, we talked about all these glucose management, but forevermore, you've all been to conference where people have talked about it, and obesity management has been just lumped in with lifestyle and left alone. How many conferences have you been to people who are going, oh, we should try lifestyle, and that's it. We've also had lots of obesity-related drugs which have come and gone. Sibutramine, all that sort of stuff. So there hasn't been a huge amount of hope for people. And finally, one more thing, the reason for obesity drugs suddenly being in the public consciousness is we live in an era of what I call is social media validation. Have you seen that? Everybody's taking pictures of themselves and putting it on social media. What is the first thing you do when you put your picture on social media? What do you do after you put it up? Do you know? You check for likes. How many people like my picture? If after half an hour nobody's liked your picture, you take it down and put another picture with a different angle. It's a world of validation, right? That's what we live in. and younger people do it more and more. So in this world, everybody wants to look a little bit slimmer, a little bit fitter, so that's why you have use of filters, VFX for movie stars, all that sort of stuff. But let's not forget the science of what loss of weight can do, why we always try and use that as a big thing. This is what happens if you lose 0 to 5%, 5 to 10%, 10 to 15%, and then 15%. So big differences. That's why we always say, can we get you to lose some weight? The problem is we're not being able to get there with all the advice. I'll ask you this question. What is the best diet in the world? What does science tell us? What's the best diet to help people lose weight? Anybody? Balanced diet? Not yet. Mediterranean, high fiber, none of those. The best diet is the one you can sustain and afford. It's irrelevant. Everything else is absolutely irrelevant. All the world data will tell you that. And we can tell you, I come from a country which has done a national diabetes, type 2 diabetes prevention program. How many people stayed on the national type 2 diabetes prevention program after 5 years? 6.6%. It's tricky. It's difficult. Diets are difficult to sustain. Diets, in a lot of cases, are difficult to afford. Argument's sake, you turn around and say to somebody, a laborer in the streets of Mumbai, you should follow the Atkins diet. They're like, क्या क्या नहीं मिलेगा? बोला चावल तो नहीं मिलेगा. अच्छा, रोटी वो भी नहीं मिलेगा. चपाटी वो भी नहीं मिलेगा. तो सर मिलेगा क्या? Different worlds. It's easy to give advice when you have a life of privilege. So, with that in mind, I'm not going to spend too much time on this. I just wanted to talk about this particular product which has come through. And the important thing is, we've had a GLP-1 analog for a number of years. This is the evolution of it, where we are moving to a double, right? 2 receptor agonists. And it's important because I always say, remember evolution. We have all lived in the world of evolution. We have done this with insulin, human insulins, animal insulins, analog insulins. This is very similar. This market's now going through evolution. And what you now have is 2 receptor agonists. And because it's separate, it's also been listed separately as something by the ADA and everything, different class. I'm not going to spend a huge amount of time on it, but this is what it does tend to do. Body weight, fat mass reduction, food cravings dropping down, they're very important, modulating fat utilization, glycemic control. All of these things, it's compounding or complementing the work of the GLP-1 analog together with this new receptor agonism. 2 trials I wanted to touch upon, and this is where I'm going to come back to the question, would you give it to your loved one? Have a look at the data and see what you think. This is what you get, more patients achieving, and the reason it's important is because the forever question is which one is the better drug, which is a good question to have. It's good we have choices when you're comparing one product with the other, and you can see the difference that is there. Tirzepatide 5, 10, 15, and there you got the Sema 1 milligram that side. That's a surpass 2. And then you have this change in weight. The top one in the dotted gray at the top is the Sema and the others are the Tirzepatide. So that's the evidence base as regards the up titration of dose, right? As regards what does weight loss do. But this is also very important because how many patients achieving the composite endpoint is very important. HbA1c, weight loss, remember what I said about what you get with the weight loss of that percentage. No clinically significant, which is what we're trying to get to with people. And you can see the number of people who get there with the doses. So that's all very well. That's a surpass 2. And then you got the surmount 5, which is in the world of obesity. And that's the big, so those of you who work in the world of obesity, these are not small changes. 15% is not a small change, but 21% is more. So these are big changes, which we haven't seen before with any product, so to speak. And the point I make on this one is that 7.9 inches of waist circumference reduction is not small. You are talking about buying new clothes. That is the big change that we bring in. So it's all about awareness of how big a change the Persian wants, what are you putting across, etc. But this is an important component, right? Would you give it to your loved one? You won't give something which works brilliantly but has lots of side effects to your loved one. That's the way we all think. Is it safe to use? And more importantly, does it have something that will end me in court? Right? So what is the main adverse events you have? Nausea, and it's very important to tell people clearly about the side effect. when you're starting off. If they can tolerate it, generally from our experience, because we use a lot of GLP-1, especially Mounjaro in the UK, you will see that if they can get past the first 2 weeks, they mostly get through it. But because it's there, no major adverse events to mention. Here is some of the sort of nausea, and you can see being the main things. I just wanted to give you one case, but before I did that, I also wanted to say is that when you use this drug, you step it up slowly. 2.5, 5, you let the tolerance build before you go up. Similar to what we do with metformin, and that's important to remember. We always go step up. So it has got data. Those are some of the side effects, and we'll obviously discuss and take questions. But I just want to show you one real-life example very quickly. 60-year-old, 9 years diabetes. That is what happened to his weight when it came down. Huge changes of weight, something we have never seen. And that's our experience as we're getting along as to where things can sit. So improvement of diabetes, weight, that big changes of weight gets us to where we get to. The real-life example of where we got to. So just a summary, we are moving across from just glucose to something we have found to try and tackle the weight. You've got newer advances in pharmacotherapy, and it's got better efficacy compared to the monoagonist. So GLP-1, this evolution of it. And just remember that fundamental question, from what I've heard, and we'll talk about this more, will I use it in my loved one? Are you convinced about using it in your loved one? So that's the fundamental science that we should always think about. But exciting times, and we shall see how we get there. So thank you very much for listening.